Dr. Ann Cotten. Dr. Cotten is the Executive Director of the Schaefer Center for Public Policy. She's a longtime employee and a fabulously productive researcher, trainer, and she has very interesting work going at SCPP. I'm Alan Lyles. I'm in the School of Health and Human Services as well as the College of Public and International Affairs. We were working on a project through the Schaefer Center, funded initially through the Department of Health and Human Services, the Center for Medicare and Medicaid Services. I'll keep talking until he says my time begins. The essence of this is that in the U.S., the costs of health care are a barrier to getting health care. And what facilitates the demand and need for health care into effective demand and receiving it is having health insurance, but we know that there are ways in which that systematically is blocked or there are strong impediments to it. Michael, are we ready yet?
I think so.
Okay. Is the timing starting?
I'm about to start it.
Okay. Let's let it go. Okay. Thanks. So I'll go first and Dr. Cotten will go second. I'll give you the mountaintops of this type of health services research, and then Dr. Cotten will tell you the practicalities of it. Because it's one thing to have an insight, a thought, a hypothesis, but it's another to have actual facts to support it, and whether we are in fact theoretically coherent, but as a matter of practicality, we're wrong. The study is access to health insurance in low-income, rural, or medically underserved areas of Maryland. And medically underserved could be urban. Let's see if I get this right. No. Well, if we could advance. I could do that. Okay, so if we look at, and in the literature review that we performed, if we look at uninsured rates, we see that there are differences between urban and rural areas, that in rural areas there are pockets of low education, which is associated with it, low income, which is associated with it, and under-resourced or low availability of care. Under the Affordable Care Act, there was an opportunity for states voluntarily to expand their Medicaid program, which could enable through insurance effective demand for medical services. And you could see that whether states did or did not expand under the Affordable Care Act, there was a difference and a drop in the uninsured rates. It was dramatic for those that expanded. It was less dramatic for those who did not. If we look at Maryland specifically, Maryland is an expansion state, and you can see precipitous drops, even though Maryland was still doing better than other states to begin with. So we have a situation in which there are still substantial numbers of Marylanders who do not have insurance. And within that, in addition to that, we have underinsured. If we look at the uninsured, we see the kinds of problems that these barriers represent are unexpected medical bills, health insurance deductibles. Everything that's navigating the healthcare system is a barrier. If you look to the column to the left, you would see it's the same problem with those who are insured, because the type of insurance we have is getting more and more costly. High deductible health plans, et cetera. I think what we have here as employees is phenomenal compared to what many have, where it's still out of reach even if you're insured. We notice that all of those problems now lead to coping mechanisms such as using the over-the-counter, complementary alternative medicines, home remedies, skipping care, things that exacerbate what the underlying medical condition is. The under-resourced, if we look at rural areas, what we see is that there are fewer per 100,000, fewer primary care physicians, fewer mental health providers, and there is more avoidable hospitalization that occurs directly as a result of that. So the question is, how is this showing up in Maryland?
So it had more results about how this is showing up in Maryland, except we were looking for a needle in a haystack, and that's kind of a lot of our problem. So there's 5.9 million people in Maryland, and the 160 zip codes that we're looking at that are either low income, medically underserved, or rural, so we had to have two of those characteristics for a zip code to qualify. We end up with 1.1 million people. The uninsured population is 71,000, so in a very small group. So this is what happened with our survey. which we're just working on analyzing the data. So out of 71,000 people that were in the possible target area, we called 42,000 plus numbers. And we only got 2.5% of completed surveys, yeah, which ended up being 1,000 that were insured, 109 users, 40 uninsured. The 109 users and the 40 uninsured were our target population. Really tough to find, and it took so much effort. Then we had to do focus groups. We scheduled 19 focus groups across the state. We advertised on LinkedIn, Facebook, Twitter. We had radio interviews. We had a website set up. We had health departments. We went to free health clinics. We did everything we could to try and get the word out about this, to get people to share information about why they don't have insurance. And we only ended up with 39 people attending, 113 people interviewing. 113 registering. The interesting thing is that, for me, this is almost a methodological failure, and our client is really pleased because of the extensive amount of outreach that we did to try and reach this target population. So we actually are in the process now of writing up our results, and we have a lot of great information to share. Unfortunately, thanks to Dr. Lyles' work, we have the national research to back up what we found in Maryland.